This is Dr. Soham Saha, consultant physician from Barashat with special interest on cardiology and diabetes. So today my topic of interest is latest update in hypertension. So as per the World Health Organization, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% of people in the 40 to 69 years of age group. Raised blood pressure is among the most important risk factors for cardiovascular diseases, especially stroke. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through the primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in the women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is the data as per the WHO and also Lancet 2021. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. Optimal care refers to evidence-based standard care of, and essential standards refer to minimum standards for care to allow specification of essential standards of care for low resource settings. The American College of Cardiology has released scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low ASCVD in adults, no ASCVD or 10-year CVD risk less than 10% with stage 1 hypertension. Management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at around 3 to 6 months, consider starting pharmacologic therapy. Acute respiratory distress syndrome or ARDS is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to the 110 to less than 130 mm of mercury range substantially reduced CV adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk findings. From now, a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150 mm of mercury. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP measurements, but also on out-of-office measurements such as ABPM or the ambulatory blood pressure monitoring or the home blood pressure monitoring, HBPM. 24-hour and nighttime BP measurements were associated with greater risks of mortality and a composite CV outcome. Thus, they may be considered as most relevant measurements for estimating the CV risk. For every 20 to 10 mm increment of BP measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Of special mention is actually the blood pressure variability, which is also associated with end organ damage. Most patients with hypertension require lifelong medical therapy to achieve the optimal BP control. The 2018 European antihypertensive drugs, the guidelines recommend 5 classes of antihypertensive drugs. Considering high non-adherence to treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitors or ARBs plus CCB or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen named NADMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would be received NDMA contaminated valsartan from Huhai every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime for these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of plus 6%. The HYGEA studies represents the largest study that tested nighttime antihypertensive treatment. In the trial, chronotherapy was associated with a significant reduction in endpoints, including the CV death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awaking hypertension therapy exerts a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during the sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with the awakening treatment. So to actually, if I want to summarize, is that hypertension is one of the most essential risk factor for cardiovascular disease, and its optimum detection via ambulatory blood pressure monitoring or home-based blood pressure monitoring with adjunct to office BP for the adequate management to a certain extent or within a specific limit is very much essential to maintain a quality lifestyle and to reduce the CV risk or the composite death. Thank you so much.